Well, hello and welcome to Lecture 21. This is Ward Stevens. The topics for this lecture include the Patient-Centered Outcomes Research Institute, also known as PCORI, and the USPSTF, try saying that fast 10 times, which is the United States Preventative Services Task Force, and then the Patient-Centered Medical Home, also referred to as PCMH. We have a number of learning objectives tied to this lecture. Please take a moment to look at those at your convenience. All right, so before we talk about these three initiatives, just want to kind of go over some of the challenges that our health system faces in trying to make improvement. One is that the diagnostic and treatment options just continue to increase very rapidly. If you watch any TV and you see the unending onslaught of pharmaceutical options out there for various disorders, and they change all the time. It's just a small example of that. But it's just not pharmaceuticals. It's options for surgery. I learned actually this morning that there are new approaches to removing or trying to treat prostate cancer, which are a whole lot less invasive than what has been done before. And things continue in all areas of medicine. But because our population is increasing, because of habits and situations, actually determinants of health, the number of chronic diseases continues to grow. Actually, the diseases pretty much remain the same. The number of individuals who have them is growing. And then we still, even after 14 years of the Affordable Care Act, we have a care system that is very fragmented, where providers do not talk to each other all the time, often working in different health systems. And then we have the whole issue of just variations in the quality of care that is provided to different populations. The care we provide is not often equitable or equal. And then, as has been noted throughout this course, the costs just continue to increase, and that is not really sustainable. Some other challenges that are out there, and this was pointed out by the Institute of Medicine back in 2013, but I'm not convinced this has changed a whole lot, is that often the clinical research that has been done really doesn't answer pressing clinical questions. They're not addressing the issues that, say, primary care physicians in the community need to have addressed. A lot of them are addressed at the university level and are perhaps addressing the needs of the patients that go into those settings. But not all patients are treated at universities. In fact, most patients are not. And then when research information is made available, it is often very difficult to get that information out to clinicians and patients. It's just takes a long time. The medical profession has its, I will just say, traditions. They find something that works, and to get new information out there to them, to encourage them to change their practice patterns can take a very long time. And then we have the whole issue of fee-for-service medicine, which, as we've noted before, has its issues. One of those being that it doesn't encourage providers to collaborate in providing care. And then another conclusion from the Institute of Medicine was that the system is so complex that no human has the cognitive capacity to be able to know everything that they could possibly know to take care of their patients. And that's part of the, I think, reason why we see a lot of specialization, which 20, 30 years ago wasn't where it is today. A general surgeon, for example, would do just about any surgical procedure that's out there. But now I'm going to go back to orthopedic surgery because that's a little better, I think a better example is that, an orthopedic surgeon, if it was a bone, they would try to fix it. But now they have, orthopedic surgeons who work on spines, orthopedic surgeons who work on hands, orthopedic surgeons who work on other particular joints, and they become very good at it. But the previous treatment options were a little more, I would say, direct than they are today. Just less, things that one can possibly do to help improve the outcomes for a patient. Then another thing we need to do is we need to address chronic illnesses. As noted previously, they are continuing to increase. And these numbers are from 2021. Those in red are all chronic diseases. I'm not sure I can say that COVID is a chronic disease. I'm pretty sure an unintentional injury is not. And then the nephrotic syndrome didn't really meet that definition either. But you can see things such as heart disease and cancers and stroke and chronic lower respiratory diseases account for a very significant percentage of the causes of death in 2021. One thing that's kind of interesting to note is that several have dropped out over the years. One of those is at one point in time, suicides were in the top 10. And I'm not sure why it dropped out, given that there seems to be an increasing rate of suicides within the United States. And then influenza and pneumonia dropped out, probably as a result of COVID moving up into position number 3. But chronic diseases are something that we need to try to deal with and address as best we can, because the impact of chronic diseases is significant. They accounted for about 55% of deaths in 2021, about 80% of healthcare spending, and they contribute to deaths and illnesses and disability. And then on top of that, talk about it increasing. Over 50% of the population has more than one chronic condition. Now, why do we have all these chronic conditions? Well, one author and many others would say that it has to do with behaviors. I would only add that our behaviors for many, are probably driven by the social context in which they live. So other determinants of health, such as education, an environment where perhaps people can't exercise, and so on. But things like tobacco use, alcohol use, drug use, poor nutrition, all contribute to chronic diseases. And we know that we have chronic diseases. We know that a lot of the causes are behavioral or social determinants, are determined, I guess, from social factors. But what are the challenges in trying to reduce these conditions? And one of them is they have a long incubation period. You just don't wake up with, say lung disease. Often it's because you smoked or someone smoked for 20, 25 years. Some people smoke for 30 or 40 years and nothing happens to them at all, really. They live long lives. My grandfather was an example. He died at the age of 84 and pretty much his entire life smoked cigars, pipes, and cigarettes. And so, but it did not really impact him until the very, very end. And then with chronic conditions, oftentimes there is no cure for them. The only thing that can be done are, well, say if someone had lung cancer, is perhaps to surgically remove a portion or all of one half of the lung. So those things are expensive. The treatment for cancers is very, very expensive. Some of those may be related to, well, things like cigarettes, or because of diet or exposures to other things in the environment. And then, being in the system that we're in, we have to recognize that preventing disease does not produce profits. Remember, we are largely in a fee-for-service environment, and you only do something and make money if you provide a service to someone. And if somebody doesn't end up with these diseases, just say diseases that might be addressed surgically, if you eliminate them, then what are surgeons going to do? They're not really interested in trying to prevent these things from happening in the first place. And then another one that I think is just important to recognize is that, at least the authors from the study back in 2017, is they noted that there is little evidence to support that investment in health education actually improves health. And a lot of, at least what I seem to hear is that if we just educate people on what they need to do, they'll do it and will avoid chronic diseases because they change their behaviors. And that may work for some, it may not work for others. I honestly don't know, but the evidence out there is really not that great that health education will actually improve health. So when it comes to addressing chronic conditions, though, even though what I said previously about the health education part is that if we're going to address them, it's probably important at least to engage them in their health. Engage the patients and their family in the decisions that are made, and also to try to prevent things from getting worse through early detections. So let's go back to the area of research and treatments, and just some of the things that I think we need to recognize is one, that screenings and tests and treatments don't always provide meaningful results for decision making. If you've ever had an annual physical, it's likely that your physician ordered a drug panel that gave I don't know how many different results. What does a healthcare provider do with those results, even if they are outside of the range? What do you do with it? And sometimes it's probably best not to do anything at all, but that's an opinion. That's why we have physicians, not people like me, running the show in the office. But anyway, we also need to recognize that research is often in controlled settings. It's not real life. It's not done out in consistently out in the communities, and then patients aren't getting this information. And even if they got that information, would they really know what to do with it? And then I think I mentioned before that often clinicians are slow to adopt new treatments. And I can't remember which drug it was. I think it was beta blockers. It took basically 13 years for the medical profession to really adopt the use of beta blockers, though the clinical evidence from the studies, again 13 years prior, said that it would work. As as I kind of noted that medicine is very traditional, has a traditional culture, and if it works now, it's going to work in the future, and it's hard to get people to try new stuff. So one of the things that came out of the Patient Protection and Affordable Care Act was the Patient-Centered Outcomes Research or Institute, PCORI. And it is the organization itself is a nonprofit. They're non-governmental, and they're an independent organization. So they are funded through the ACA through assessments on private insurance. And in addition to that, there is money that comes from the federal, through the federal government, from just kind of general fund appropriations. The government collects taxes, it goes into the general fund, and then a portion of that gets allocated to this organization. And it is pretty well funded through at least through 2029. The budget range is $275 million to $399 million per year. So what is PCORI supposed to do? Well, they are supposed to do research that compares treatments for a condition against other treatments to determine what works best for different individuals. And not really necessarily tied to this. Well, it's kind of tied to it in terms of concept, is when you think about value-based insurance design and providing clinically nuanced care, is to recognize that what is of value to one individual may be different than what it is to another. And I believe the previous example that I shared was that if you don't have a family history of colonoscopy, then you follow the guidelines. You get your first one at age 50 and every 10 years after, or whatever the time period is. However, if an individual has a family history of colon cancer, then you may need to start screening them at age 30. And in addition to that, there are certain conditions that present themselves in different populations. So it needs to focus on, you can focus on different ethnicities about what should be done for those groups. And then there's other cultural differences as well. So basically, what they're out there to do is to find out what works best for different people and groups. And then what their vision is that they want patients and the public to have that information so that they can use or make decisions that reflect their desired health outcomes. And again, that can be very different for different individuals based on their backgrounds, where they're from, and their culture, etc. So their mission is overall is that they want informed healthcare decisions. They want to improve the delivery and outcomes of care, and to base this on evidence-based information. And as they go about their mission, they include all groups. They're very inclusive in how they go about things. Definitely, you have to have patients do this type of research. However, they also involve caregivers and the healthcare community overall. As I previously shared, it's a non-governmental, though governmental funded. So the government probably does have some sway over what they do. I think they do, because since they're providing the funding for it. But all their proceedings are open to the public. And when they make recommendations, they do not consider the cost. Nothing, they may come up with something and say, hey, this is the best thing ever. However, they cannot mandate that health insurance companies pay for things that work. So they're really making a patient-centered decision, or recommendations. This is what works for this group of individuals. Now, here's some more information if you are interested. The first video there is about 11 minutes. And if this is something that you are interested in, and you probably perhaps will in one day, may want to be part of this, but it kind of provides, again, who they are, what they do, and how you could actually get engaged with it as a healthcare provider in the future. If you don't want to watch the long one there at the top or the bottom, I would encourage you to watch the one in the middle at 2 minutes and 8 seconds, which I think gives a pretty good short overview of what they are about. So a lot of their, what are they focusing on? They focus on conditions that are a heavy burden on families and the healthcare system. They often look at chronic and or people with multiple conditions or rare and understudied conditions, and then kind of trying to work in the area of providing equitable care, conditions that have varied outcomes across different populations. Now, this following slide is a little, I haven't found this, I think is no longer on their website, but some of the things that they want individuals to be able to answer, or patients, are things like this. Given my personal characteristics, conditions, and preferences, what should I expect will happen to me? A lot of times you go into the healthcare system, and I mean, frankly, it's kind of scary. You don't know what's going on. You don't know whether it's going to work or what. And it's good to have that information. Another thing that some of the research has tried to answer are, are to be able to tell people, or what are my options and what are the potential benefits and harms of those options? Because with most diseases, there's more than one way to address it. In the area of prostate cancer, you can have it removed. They can use radiation. They can use chemo. They can use seeds. They can do nothing at all. And so being able to have that and consider that can help the patient make the best select the best option for them. And if they select an option, it would be also good for patients to know what they could do to improve the outcomes that are most important to them individually. If the if somebody has a rare cancer and perhaps they have young children, do they want to, the options might be, oh, I go on chemo, that's going to be really rough. I'm going to feel horrible all the time. Do I choose, and maybe there's a slim chance of long-term survival. Do they choose that route, or do they say, look, I'm just going to, live with this best I can and have perhaps a higher quality of life for a shorter period of time? So that decision may be very different for different people. And then also the kind of the final question they often try to address is, how can I work with the health system to, make the best decisions about my health and healthcare. So a lot of it is just, the point of this is you don't need to remember these questions, but to remember that Patient-Centered Outcomes Research Institute is really trying to help people and individuals make the best decisions for themselves. Maybe not the decision that someone in the health system may want to make for them. PCORI has had a lot of funded projects. About $3.2 billion has been funded, probably over that, more than that by now. They've had over 1,800 projects that have been approved or in process. And if you're ever interested, you can take a look at them. The total portfolio there is the top link. And then there's some other links there as well. Just examples of things that they're looking at. So PCORI, funded by the ACA. How does it jive with the 6 aims of quality? And I think patient-centered is pretty obvious, but it also I think can help with providing effective or evidence-based care that works. It could also help provide timely care if patients know that they should receive certain types of perhaps screenings or they should do certain things to improve their care. Could help with things being cost effective by helping patients go to the route that they is best for them versus trying to find do different routes possibly over a period of time. And then I think the other one, and probably the two most important, are the patient-centered and also being equitable, to make sure that the quality does not vary based on individual characteristics. And what is quality for one person may be different from another, but if you involve the patient in it, you give them their options, and they get to determine what that quality is. So that's a little bit about PCORI. Now let's move on to the United States Preventative Services Task Force, or the USPSTF. There's a nice little short video there. It's only about 2 minutes. Please take a moment to watch that one. But it's pretty simple. What they do is they provide patients and providers evidence-based recommendations regarding preventive services. So things like that colonoscopy or breast screening cancers or behavioral screenings, things like smoking or depression and those types of things. So the USPSTF, similar to the PCORI is an independent panel of non-federal experts in prevention and evidence-based medicine. The USPSTF was not established by the ACA, a fact you don't need to know, but it was not, but is primarily composed of primary care providers. And what they do is they conduct scientific evidence reviews of clinical preventative healthcare services. They don't necessarily do the research themselves. PCORI is funding research, but the USPSTF looks at the research that has been done, and what they do is develop recommendations to be used primarily by primary care clinicians. And they publish these recommendation statements. And so the recommendation statements, again, you don't need to be too concerned about this, other than that there is a grading system. And so you can see that it's just A, B, C, D, and that if it's an A, that it's recommended. If it's a B, it's recommended. And just a little, but an A is a high level of certainty, a higher level of certainty that the net benefit is substantial. With a B, moderate certainty that the benefit is moderate to substantial. And then the C and D, you can see less certainty. So what are the benefits of this information? One is that it can help make decisions that result in better patient outcomes, and that the decisions are cost effective. So the USPSTF is tied to that thing called an essential health benefits. You may recall from previous lecture that essential health benefits are the benefits that have to be included in all health plans. And so if a service, screening or counseling, receives an A or B rating from the USPSTF, it is included as an essential health benefit without cost sharing. And you remember cost sharing is your coinsurance and co-pays and that type of, whatever's out-of-pocket expense. So there is no cost sharing for these services. So for, example, I keep on picking on colonoscopy because that's one near and dear to my heart, is that when you go for that, you don't have to pay a copay. There's no co-insurance whatsoever. But the interesting thing is, and many patients may want to remember, and you may want to remember this when you're recommending services to your patient, is that the anesthesia that's often provided with things like a colonoscopy does require the cost sharing. So the colonoscopy has no cost sharing, but the anesthesia service, you'll have to do whatever the copay or coinsurance with that, meeting your deductible and so on. And also kind of a little twist on it is if the diagnostic colonoscopy turns into one where the something search is removed, then it's not going to be fully covered because it went from a screening to a treatment. But I think the good news is that, or a point of it, it's kind of related back to value-based insurance design. I already mentioned that once, but it removes the financial obstacles for patients to receive services that are of clinical value, specifically high clinical value. So very consistent with the concepts of VBID. So what might how might this information be of value to you? I think one in the short term is that you can, I'll show you in a few moments, where you can go to get this information. But when you're out there in a medical practice doing a rotation or whatever, you can find out, and you're seeing a patient or helping with a patient, you can find out what types of things would be beneficial to them. In my perfect world, all EMRs would be tied to the USPSTF recommendations to make sure that physicians are addressing them on every single visit. And that may happen in some, I'm not sure. But again, the USPSTF is kind of aligned with the 6 aims of quality, one in the sense that it is evidence-based. I think one could also argue that it is patient-centered, not necessarily, I would say, it's kind of patient-centered in the recommendations that you are making are directed to their specific situation, maybe not their values or their preferences, but maybe things that they should consider. Can also, I think, address issues of timely care, making sure that things are cost effective and also equitable. Now, the USPSTF, one of its kind of shortcomings is it breaks all patients down into male and female and by age group, and then some other characteristics you have to put in there as well. But what it doesn't really recognize at this point in time is that the needs of different of populations may be different. There may be certain screenings that you would not do for a white individual that you might want to do for a black individual, and it may be things that go the other way around. But it'll take a lot of information, I think, for the USPSTF would need in order to make that recommendation. But some things I've read recently suggest that they're trying to go that route to make it even more specific than it is now. Now you can access this information. They have an app. If you go to this app store on your phone, if you stick in the USPSTF in there, then you can download this app, and I'd encourage you to do so, and just kind of see how the system works, and maybe a benefit to you. But I think it can be a great benefit to how you deliver care to patients in the future. So 2 recommendations or 2 abbreviations that you probably want to remember are the PCORI and USPSTF, because I may use the acronym versus spelling it out on an exam. I'm not sure how I'm going to do that yet, but those are long words, and it's I think reasonable to expect if you're going into healthcare to know the abbreviations that are that you're going to probably run into. So that's PCORI and the USPSTF. Now let's spend a little bit of time on patient-centeredness. I think we've perhaps seen this definition before. Don't really need to know that definition, but you can see how it kind of ties into PCORI. But it'd be good to know this, is that to provide a patient-centered care requires a partnership. It's a partnership between the care team as well as the patient and their family or whoever is representing them. And that patient-centeredness will always respect patients' wishes, regardless of whether the care team agrees with that or not. The example I always use, and perhaps I've used it before in previous lectures, is we may not agree with the Jehovah's Witness who comes bleeding into the ER and they need blood and they refuse it, and they may die if they don't receive it, but that's their wish. And then patient-centeredness is a lot of emphasis on educating and supporting the patients to help them make the best decisions for themselves. Now, the patient-centered medical home was defined back in 2007 by a group at the Robert Graham Center as likely to be the best opportunity for aligning physician and patient frustration, demonstrated models for improving care, and private and public payment systems to produce the most profound transformation of the healthcare system in anyone's memory. So this is not a new concept. It's not part of the ACA. Again, it was actually introduced by the pediatricians back in 1967. They adopted it as a policy in the 70s. The World Health Organization kind of defined what a medical home is. South Africa had some success with medical homes, and then the pediatricians back in 2002 identified 37 specific activities that a PCMH ought to be involved in. And I would agree that this is a great model, and that we probably should be doing a whole lot more of it. And if we did that, we provide better primary care and have provide a lot better value. And you may ask, well, if it's so good, why haven't we done it? And I think part of uh, the issue is the way the healthcare system is reimbursed under fee-for-service medicine primarily. If we were reimbursed, or the healthcare was reimbursed, say under global payments, and was responsible for a given population in say in a certain geographic area, then it might be more likely that this model would be adopted further. But it has expanded over the years. About 20% of primary care physicians currently practice in a PCMH. There are about 100 payers that support it. Other payers, meaning not necessarily Medicare, Medicaid may provide for it in certain states. I do not know, but your commercial insurance companies will pay more to practices that meet the requirements for a PCMH. And usually what that means to meet those requirements is that they have to meet standards established by entities such as the National Center for Quality Assurance. But a patient-centered medical home has several core components, and we will go over many of those in the next slide, so I'm not going to read them here. But the first one is that that patients have a personal physician, because I think and I think we would all recognize that one of the things that we would like to have is a primary care physician who knows something about us. I've been fortunate to have the same primary care physician for 20 years. And he knows some stuff about me. I know some stuff about him. We talk about it when I go for an annual visit. And the thing is that going back to fee for service, it kind of creates barriers to developing relationships with patients, because that physician needs to get on to the next patient. But in a patient-centered medical home, is because they receive additional payments, perhaps they can spend more time to develop those relationships. And it has been shown, or at least is reported by the researchers at the Robert Graham Center, is that having one physician who's providing and coordinating care helps to lower cost and improve outcomes. So, it's not always possible for all people. We're very mobile today, a lot more mobile than we've been in the past. So if you move from community to community to community, this would be harder to do. But if you remain in the community for a period of time, it's really nice to have a physician who knows who you are. And then the second thing related to that physician or physicians is that the medical practice is actually, or the care that's delivered by a multidisciplinary care team, is directed by a physician. And the kind of a key role of the physician is to make sure that issues do not fall through the cracks. If a patient needs, for example, a mental health access to mental health services, the physician can make sure and direct the staff and the members of the team to make sure that service is provided. And another kind of thing there is that it's a multidisciplinary team effort. Many others, the care typically in a PCMH is more comprehensive, and maybe more people working in the office, and so somebody needs to kind of direct that team. And then another focus is that needs to be a whole person orientation. A patient-centered medical home is typically set up to care for all stages of life, typically cradle to grave. And it deals with the body, the spirit, sometimes referred to as the mind, and is a culturally appropriate. So in one sense, it is providing care that is consistent with osteopathic medical principles. And I think you have to take care of all those things. People are more than just the disease, the diagnosis, the account number that they have when they walk in. You need to take care of the entire person. And then, kind of related back to the physician-directed care, is that care is also coordinated and or integrated. And it's responsibility for a PCMH to make sure that care is coordinated across all the healthcare settings. If a patient needs to have surgery, the PCMH is going to make sure that the patient gets to the care that they receive, which also requires that information be transmitted to the appropriate parties, because we have to remember that patients are not always the best at communicating information. So the PCMH has to take responsibility for that. And then we also, anywhere we go for care, we want to make sure that the care that is provided is of quality care, and part of that is being safe. So the PCMHs will try to focus on the use of evidence-based medicine. They may be making sure that the recommendations from the USPSTF are being implemented for their patients. They also will measure their performance, and to check and say, okay, what percent of our diabetic patients have their the A1C at the right levels? What percent of our patients are getting the screenings that they need to receive? So that is kind of a requirement. And many operate as many practices operate as a PCMH, and then many of them will be accredited. I think I may have said before they have to be accredited. That was an incorrect statement, but I'm not going to test you on that anyway. But just the National Committee for Quality Assurance is a route that they can do. And then an interesting thing that has not really happened, at least in my experience working in hospitals, is that patients were not, pretty much never, involved in any quality improvement initiatives. But it seems PCMH tries to get that input from the patient. And that's very important. The healthcare providers can maybe come up with good ways to improve a process, which may improve the patient's outcomes, but what they do may not make the patient, provide the patient a good experience of care. So involving the patient in that process can help improve that. And then just on the quality side, also I think the safety side, also having to deal with the transfer of records between practices, is that you have to use that electronic health record. And then PCMHs, well, you got to be open. Most PCMHs will have more early morning to at least early evening hours, often provide access to electronic records. A lot of health systems now have things called like My Chart or something along those lines. And the system also allows patients to schedule their appointments online. So if you're going to provide good care, it has to be available care. So what types of organizations are PCMHs? They can be private practices. They can also be government funded. Many, and I'm just going to kind of talk mainly about those that are federally funded. The Health Resources and Services Administration funds a lot of these clinics, typically known as a federal qualified health clinic, and we'll talk about that on the next in just a moment. But in the last numbers that I saw, or at least the ones that are here in this presentation, is that the number of patients that are, receive care through a HRSA-funded clinic is relatively significant, about almost, let's say 9%, 8-9% of the U.S. Population. And in rural areas, about 20% of rural residents go to HRSA-funded clinics, and about 1 in 4 of the uninsured. And many of these are what is known as a federally qualified health clinics. They are always community-based. They are located in medically underserved areas or health professional shortage areas, which we talked about during the lecture on access and the workforce. They have some stringent performance requirements, primarily directed toward patients meeting things such as their A1C levels, but they accept on the financial side of things. It's basically on a patient's ability to pay, and so there's a sliding fee scale. If you are, say, 50% of the federal poverty level, you may pay close to nothing. If you are 200%, you may pay somewhat more. And the governing board, and this kind of goes back to the kind of similar to the patient-centered medical home concept, is that patients have to be on the governing body, that entity which is responsible for the operations of the clinic, which gives an opportunity for patients and the community to kind of impact and provide direction on how care should be delivered to the population that is being served. Now, being an FQHC has some potential benefits to it. One is that they are eligible to receive funding to be a teaching health center. And a teaching health center is, as the name implies, serves as a training site for healthcare professionals and specifically physicians. So historically, physician training programs, residency programs were all funded through the Medicare program, and all of those payments went or have to go to hospitals. And that's where most of it goes today. However, the teaching health center allows an FQHC to be paid to actually train medical residents. And kind of the drive for that, is just a recognition that most primary care is not provided in hospitals, but most primary care physicians do the bulk of their training in hospitals. And so this model allows the a primary care location to train physicians who are going to do primary care in a primary care setting. Now, that doesn't mean that all the requirements for residency training go away, because to complete a residency, you still have to meet that requirements, but a lot more of it will occur in this primary care facility. And then another program out there is the National Health Service Corps Loan Repayment Program. Again, if most FQHCs all FQHCs are going to be in a HPSA or medically underserved area, which makes them eligible, or physicians who go to work there, to be able to apply for loan repayment in the National Health Service Corps. So if you were ever interested and you would consider going into a rural environment, into that HPSA, working in an FQHC, this is something that you would have to look at, you could look at as well. So we have the FQHC, patient-centered medical home, and the question is does it work? And some areas that have been measured are, access. Is it improving or eliminating health disparities? What's its impact on cost and utilization, quality, and satisfaction? Now, I've only been able to find one study on it, but on quality measures, in areas the PCMHs showed some improvement. In some areas they outperformed, and in some areas there were no differences at all. So 4 measures, no difference. Some modest improvements, some. So I guess when you look at quality, it's at least in some areas, they seem to be able to improve the quality of care that is provided. On utilization measures, they did find that PCMHs did more primary care visits, which resulted in fewer specialist visits. And I would say that's a positive thing. One, it'll lower cost. It prevents the patient having to go somewhere else to receive care. Also increases access to specialty care because patients who could be taken care of at the primary care level didn't take up time in the specialist office. And they're also associated with fewer diagnostic tests. That's a kind of advantage of having a practice location that knows a patient, a physician that knows a patient. They're not, they have that history, so they're not going to go out and order everything every single time. So the other area of access, I'm not sure exactly how, this is from the National Committee for Quality Assurance, is that it seemed to increase access to higher rates of cancer screening, which would be a positive. That's the only measure I could find related to that. But in the area of disparities, which may be also related to access as well, is that PCMH has had increased cancer screenings for lower income individuals and reduced the disparity in breast cancer screening by about 50%. And that is very, very significant. So I think it's maybe one of the things that helped. If you remember back from the quality lecture, I believe that one of the things we do well in the United States is breast cancer screenings, and I think PCMHs, FQHCs helped contribute to that performance. On the cost side, it did slow the rate of emergency department visits compared between PCMH beneficiaries and non-PCMH beneficiaries, which is a good thing. The cost per Medicare beneficiary went down about 5%, and what's really significant was a 60% lower hospital spending between the two groups, as well as reduced use of advanced imaging. Again, I think this all points just to the value of providing a patient-centered primary care. That if an individual's care is managed in the sense from a medical side, it kind of, I guess, eliminates the ability of the fragmented system to just generate more and more spending. And then on the quality side, again, maybe a little overlap with some of the things I've shared before, but it did increase screening rates for depression. Diabetic patients were more likely to adhere to their protocols, and more patients received eye examinations, and I think that's probably the diabetes patients as well. And then in the area of satisfaction, when Medicare beneficiaries are asked about it, they would want PCMH style care. And I personally think that any individual who knows what a PCMH is would love to have a PCMH care. One place where I can go for care and somebody's looking at everything and making sure that my care is coordinated, things aren't falling through the cracks, and I'm not having to go to the ER or self-referring myself to an orthopedic surgeon because my knee hurts, etc. And so a pretty good model. And kind of a gripe I personally have is, if the PCMH model is so good, why doesn't the federal government basically pay everybody like their federally qualified health clinic? Because what I didn't mention before is federally qualified health clinics, they have to do more, but they get paid more. But to become a federally qualified health clinic, you have to apply for a grant. And the grants are very competitive. The opportunity to apply isn't but every so often. It's dependent upon how much funding that the federal government provides. And so, I personally think that if you had requirements or standards for a PCMH or an FQHC, that if I can show that I meet the standards, then I should receive a higher rate of reimbursement. Because if you are receiving, your typical payments from fee-for-service payments from a health insurer or from a government program, there's really not enough money in the system to help to fund it and make it worth a practice's while. So that's PCORI, the United States Preventative Services Task Force, and patient-centered medical homes. And don't forget, remember what FQHC is, some abbreviations you probably want to know. So thank you for listening, and please let me know if you have any questions.